So we'll go ahead and get started. Hello, everyone, and thank you so much for joining us today. It's been a great pleasure to have you all today with us. And before I introduce our guest speaker today, I'd like to introduce myself. My name is Ashraf Gorgi. I'm the director of the Spinal Cord Injury Research at the McGuire VA Hospital in Richmond, Virginia. Also, I'm a professor of physical medicine rehab at Virginia Commonwealth University. It is our honor to introduce Dr. Chester Hu, who is a professor and division director of physical medicine and rehabilitation, endowed chair of spinal cord injury research at the University of Alberta and Alberta Health Service, Edmonton Zone Section Chief of PMNR, and AHS Senior Medical Director of the Neuroscience Rehabilitation and Vision Strategic Clinical Network. Dr. Hu graduated from the University of Cambridge in United Kingdom before moving to the United States, where he completed his residency in PMR at the Harvard Medical School, Spaulding Rehab Hospital, and fellowship in SCI medicine at the Kessler Institute for Rehabilitation, University of Medicine, and Dentistry, New Jersey. Dr. Hu has a special clinical and research interest in health service delivery for persons with SCI, as well as the rehabilitation management following SCI, such as the use of functional electrical stimulation to promote neural recovery. He is particularly interested in the integration of research into clinical practice. Thank you, Dr. Hu, and looking forward to your presentation.
Thanks so much, Ashraf. And let me share my screen. And okay, can you see this okay?
Yeah, we can see it.
Perfect. Okay. First of all, thanks so much for inviting me. And it's really such a pleasure to speak here today. And I also want to say that, hi to Dr. Stephen Kirschblum, because he was my mentor during my fellowship and actually for the rest of my career as well. And he inspired me to do what I'm doing today. So thanks so much for being here. And so the topic today is, about functional electrical stimulation cycling and whether it's safe and feasible after acute spinal cord injury. I want to just go through the objectives. The first one is to discuss the potential benefits of FES cycling early after spinal cord injury. And then the second one is to describe the lessons learned from FES cycling early after acute SCI, and that's from the study that I'm going to talk about. And the third objective is to discuss the future research and clinical opportunities for FES cycling early after acute spinal cord injury. Now, I want to say that basically I'm sharing my perspectives here in Alberta, in Canada. And I understand that the audience is North America and international as well. So there may be different perspectives and different practices already. So please bear with me for that. And before I start though, I want to share this disclaimer that I have no financial conflicts of interest to disclose. So for this group here, I think that, it really needs no introduction as to what FES is and why we're using this after spinal cord injury. So of course, FES stands for functional electrical stimulation. And basically, it is the use of electrical stimulation to activate muscles. But I have to say that even though that's what we think a lot about, but probably it affects, the sensory system just as importantly. But for the purpose of this discussion, we'll really focus on the muscles. And so FES can make muscles paralyzed by spinal cord injury contract to perform functional movements such as cycling, especially, right, with the support of the appropriate software and programs. And we know that in chronic spinal cord injury, FES cycling can reverse muscle atrophy and also improve functional performance as well. That's been studied for a long time. But we still have some other pending questions out there, like its effects on bone loss, etc. But regardless, we know that it can be beneficial in certain individuals after their spinal cord injury. And so can FES cycling start earlier though? In acute spinal cord injury, I'm talking about less than 3 weeks after spinal cord injury. And why do we think that? Why do we want to know about that? So the questions that we had were, can it actually prevent neuromuscular degeneration, looking at the muscle loss and bone loss that really occur rapidly, right, after SCI? And could that actually intervene the development of spasticity? That's actually a big question that my collaborator, Dr. Monica Gorsini, has, because she has a big interest in spasticity after SCI, and she sees that as a maladaptation of the system. So if we start exercise training, including FES cycling, early on, could that actually stop the development of this maladaptation? So that's a really good question. And also, the question was, could we actually also start exercise training early enough so that we could stop the development of neuropathic pain as well? So those are some of the questions, as to whether earlier use of FES cycling may have an effect on these things. We don't really have the answers yet, but that's what we want to really find out. And then the other question is, could that really promote neural recovery through neuroplasticity? And we know that in animal models, potentially we could do that. And especially if we start early. However, we also want to be mindful that if we start way too early, it may actually make things worse. So we need to learn about when it is safe and feasible to do so, and yet we don't start that too early as well. And that's what we still have to learn after we have the animal models. Oops. So before I talk about, all of those things, I want to give you some context here. Why am I even interested in doing all of this, right? In the context of patient care and in the context of the healthcare system. So I came to Alberta from the States in 2011. And so that's 10 years ago. And at that time, FES cycling was established in the community in Edmonton, Alberta. Edmonton is the capital of Alberta. There are two main metropolitan areas in Alberta, and Edmonton's one and Calgary's the other. And just for your interest, it's a province of about 3.5 million people, and then most people live in Edmonton and Calgary. And then it was established in the community in Calgary later on. And, it was great to have this in the community, but people kind of found the programs, by themselves after their spinal cord injury. And they really, just happened to find out about it, but then it really wasn't connected to the healthcare system. And then after that, I worked towards establishing FES cycling in the rehabilitation settings. So that came after it was established in the community. So then we have the FES cycling program in the rehab settings, and then people would start that in rehab and then would continue with that in the community setting. So we still have to work on that a lot more, but at least it was started. And now the goal is to establish FES cycling in the acute care setting, with all of those questions that I had mentioned in mind, right? And to that end, we have established a provincial working group to connect the stakeholders in all the settings. So these are clinicians, researchers, administrators, funders, etc. We brought them all together to talk about how we want to do this so that ultimately we can establish the availability and practice of FES cycling along the continuum of care. And so that's what we're hoping to achieve. And that's what we hear a lot from our patients, that they would like to see this to be available along the continuum. And so that's the context as to why I'm doing this work, both in research and also in the healthcare delivery. So let's look at what we use for FES cycling here. And I think just like many settings in North America, we are using the restorative therapies, RT300 sitting bike for the most part. And we're using this system with 12 channels. And this was actually one of our study participants. And as you know, we have the electrodes in the lower extremities, in the glutes, etc. And for this particular model, you pull right up to this FES cycling machine. And I do have to say that, though this is the model that we're using for our project, and as in many settings in North America, but around the world, there are many, many different models. And also the price points really vary tremendously. And I think that's an important consideration, because the ones that we use in North America are very expensive, and it really makes financial accessibility a big issue for many people if they want to use it in the community and also at home. Whereas there are many models from Europe, etc., which are much more affordable. But anyway, just wanted to bring that up, not that we want to focus on this issue here today. And then also, for the purpose of my study, we are using the supine bike as well. And this bike is actually really useful in the acute care setting, especially even in the ICU setting, because the users can be supine, they're not even right up in a wheelchair, and yet in the supine setting, they could actually use this bike to do similar cycling. And in fact, this has been studied in other conditions like stroke, at Johns Hopkins, and I believe Ottawa Hospital as well, and using the supine bike. And so it is totally doable. And for spinal cord injury, we are hoping that we can do this eventually in the ICU setting, but at least we are now using this in the acute ward setting, such as the acute spine units and trauma units. We have been using this particular model. And this is our research nurse, Yoshi here, demonstrating how this looks, how this works for us. Now, if we look at the literature for FES cycling, basically most studies are on chronic SCI. And by chronic, I'm talking about over a year after the SCI. I'm sure that you're all very familiar with the literature. And as you know, FES cycling is not anything new because it's been around for over 20 years, right? And yet, I think that despite the fact that the technology is there, and I think in terms of its implementation and also clinical utilization, there's still room for improvement there. And so some people may say, hey, it's been out there for so long, why do you even bother to study that? And so my answers are, first of all, the studies have been mostly in the chronic setting. And we need to learn more about the acute care setting. And secondly, because the technology is out there, and yet the implementation really is not everywhere, right? And that's exactly why I want to study this, so that we can see what the gaps are and how can we promote technology to be adopted in the clinical setting. And as you know, right, there's this valley of death in terms of implementation of new research-based practice and technologies. And so that's exactly why I want to do this. So just because the technology is not new, it doesn't mean that we don't want to look at this to study that for the right context and to support implementation. So if we look at the studies on the acute care side of things, I'm talking about within 3 months here for this purpose. So there are studies that looked at muscle atrophy, and there are a couple studies that look at bone density. And most studies have a smaller sample size, and also the vast majority of the studies started at 4 to 9 weeks post injury. And one could argue that that's still not as early as one may want to see. I think that is yet to be determined. And the largest study and the most recent study is from Australia with a Gallia study. And she started FES cycling with a large number of people in Australia, less than 4 weeks post-injury. And her um, participants were about 12 to 30 days post-injury. And the study was great because it's a large upscale study and it was early after SCI. But her focus was really mostly on muscles, on exercise physiology and muscle atrophy. And so we still need to learn more about all the neurologic situations and recovery that I talked about early on in my slides. And so I think that we have lots of opportunities to study this. And so in order to understand how we can start FES cycling early after SCI, um, we know that despite the fact that there are a few studies out there, but no study actually talks about how you get that started and what parameters to use and how feasible, how safe, and what the procedures are to do this soon after SCI. So, we're scratching our head and we just couldn't find anything like that. And everybody was using different parameters. There's no guidance out there. No wonder why it's difficult for people to get things started, right, in the clinical setting. So we thought, let's do this systematically. Let's first of all establish the safety and feasibility and procedures for early FES cycling as soon as possible after SCI in the acute care settings. And so we are doing this at the University of Alberta Hospital, which is one of the level 1 trauma centers in Edmonton that take people with acute SCI. And then the lessons learned will guide the development of clinical studies for FES cycling after acute SCI. And also, through this, we'll build the expertise and experience in early FES cycling after SCI among my research team members. Though I have a fantastic research associate, Dirk, who's a PT PhD with years of experience of SCI and FES cycling. His experience was really with chronic SCI. So acute SCI is a whole new thing for him. And with my research nurse, Yoshi, who is actually a clinical nurse in SCI, as well as somebody with a master's degree in neurophysiology. Doing this in people with acute SCI is also brand new for her. So it's really great that through this study, we can also help them to gain this experience as well. And then one important aspect for our study for the safety and feasibility study is to start to engage the acute SCI team for future clinical implementation of FES cycling. So we're taking this very much integrated knowledge translation, the IKT approach, to see how we can really build this whole thing from the ground up together with our clinician partners and also management partners. So this is our study. We basically wanted to include people with traumatic or non-traumatic SCI, and the non-traumatic ones need to be those with an acute onset. And we were considering patients on the neuro, ortho, and trauma units at the University of Alberta Hospital. And people could be paraplegic, they could have tetraplegia, and they may have incomplete or complete injuries, so AIS A to C. And people may ask, why are you doing this on people with complete and incomplete injuries? I would argue that we actually don't know what happens, right? For people with complete versus incomplete injuries with FES cycling, especially for acute use. And so that's why we wanted to include people with complete as well as incomplete injuries. And the injury would be sustained within, the first 3 months after their accident or injury. And the age would be 60 to 90 and any gender, and medically stable as determined by their clinical team. For exclusion criteria, so people with unstable fractures would be excluded. And I emphasize unstable fractures because obviously a lot of the patients have had fractures in the spine, and some actually had fractures in the lower extremities, but they were deemed stable by the clinical team. So we still proceeded, which was excellent. And pregnancy would be a contraindication in this case, just because we don't know what it could do to it. Now, AISD is probably something that we should have included, but at that time, we're looking at what the other acute studies did. And for the most part, they're looking at people with AIS A to C, and that's why we did not consider AISD. But honestly, looking back, hindsight's always 2020, right? We probably should have included people with AISD, but that was just a safety and feasibility study anyway. It's not an efficacy trial. And obviously, those people who couldn't give consent, and now relative contraindications include polycontrol spasticity or autonomic dysreflexia, and pressure injury in weight-bearing areas, etc. So our protocol was that we would do FES cycling 3 days per week, and the goal was to do a total of 4 weeks of cycling at least. And we'll follow people for up to 3 months. So, they may start at the acute care setting, and then during the 3 months, they may continue with the FBS cycling protocol at the Glenrose Rehab Hospital, and also, if necessary, in our lab after discharge from Rehab 2, because we wanted to see how people do over time. And so we used the RT300, as I mentioned, the supine bike mostly at the University of Alberta Hospital, and then at the Glenrose Rehab Hospital, and in our lab, we would be using the RT300 with the wheelchair use. And stimulation for the supine protocol would be in the quads, hamstrings, and glutes. And for the sitting protocol, it's got 12 channels, and we would be doing adding a gastroc and tip end as well. And we basically started, these parameters, right? We had to start somewhere. So we looked at, what people were using and what the company was recommending. And so we started off as a baseline these parameters with a frequency of 35 hertz, a pulse width of 300 microseconds. And for the first session, we aim to do 15 minutes only of cycling at 20 RPM. And the goal is to progress to 45 minutes per session at 30 to 50 RPM. Now, for the purpose of today's discussion, I'll focus more on the safety and feasibility, but then we also, looked at how people were progressing during this time and how we actually adjusted the parameters, what we learned about the progression, and that would be a whole different discussion. And we actually also just got our paper on progression accepted as well. And so I won't focus on the progression here, but rather the safety and feasibility. So here are our outcome measurements. So we looked at several areas, right? For feasibility, we looked at the practicality, patient readiness, and also acceptability. So for practicality, we're looking at the timing, the logistics, how that actually may interfere with daily care, and the problems caused on the nursing unit or not, and also the time per session as well. And like how much time it would take to get ready, for the donning and doffing of the system, etc. And then patient readiness. For the medical issues, that may interfere with FES, and also any discomfort or pain during FES. Then physiologically, we looked at, whether people were able to have a good contraction with FES and their tone, and whether they were in spinal shock. Then psychologically, we wanted to see how people actually may benefit emotionally, and also how they would adhere to the protocol and the usage, not just during our study, but also over time as well. And also for acceptability, we looked at their consent rate, dropout rate, and satisfaction, and not just for the participants, but also how the clinicians perceive that to be appropriate and useful for their clients as well. So those are the areas that we looked at for feasibility. For safety, we looked at the adverse events, and we had a whole log sheet that would report anything that's associated with with FES, with the protocol. But obviously, for study purpose, we have to look at report everything, even if it's not directly related to FES cycling, right? So in terms of other outcomes, the procedures and efficacy, like I said, we're looking at the FES parameters and cycling progression. And then for efficacy, we're looking at muscle mass and the neurologic status, such as spasticity, development, reflexes, muscle strength, sensation. So essentially, we're doing the INSCI exam, and then we looked at the modified Ashworth scale. We're looking at the pain using the modified pain basic data set, and also depression with PHQ-9, etc. These, like I say, we're reporting that separately, so that won't be the focus of our discussion today. So in terms of staff engagement, that's really critical for the success of our study. And at the University of Alberta Hospital, this is actually the first rehab research study on patients with acute SCI at UAH. And they had other intervention studies, by the acute care team, but in terms of a rehab research study, this was the first one. So they were actually very excited. And we had support from the spine surgeons, and it's endorsed by the unit management and directors. And we have multiple in-services for the nursing staff and allied health staff on all of these units, and they're very well received. So let's look at the results for our safety and feasibility parts. So in terms of our patient screen and reason for exclusion, we screened 72 people, and we enrolled 7. So you may think that is such a low enrollment rate, but you see why. Basically, we did not take a number of people with AISD. Like I said, that was probably a mistake, on retrospect. And then many patients were actually, screened, and then rapidly they were transferred to other facilities, so we couldn't enroll them. And then some patients were screened, but they had spinal metastases and also other issues that made them inappropriate. So I don't want you to believe that this recruitment rate of 9.7% was really showing that it's not feasible. It was really just how we selected our participants. So it's not really a feasibility thing here. And um, then when we look at who they were people, who range from age 24 to age 64, and 2 females and 5 males, and AISA. We had 3 of them, 2 AISB and 2 AISC, and their level of injury range from C4 to T12, and most were traumatic injuries. One had an acute vascular onset due to AVM in the spinal cord. And then in terms of the date of the start of FES, basically it ranged from 12 days after the injury to 33 days after injury. So the mean was 19.9 days. And in terms of FES cycling, you see that 3 participants really had a lot of sessions, and some had very few sessions because of other reasons that we couldn't really continue. But if we look at those who actually participated in the sessions for a long time, we actually gained lots of experience from that, because altogether we did 103 sessions. So from that, we gained lots of information and experience. By the way, I also wanted to show you that we had some concomitant injuries, like people had chest tube with pneumothorax, but they're stable. So the surgeon was okay for us to go ahead, and we did it. It was fine. Had rib fracture, scapular fracture, midfoot fracture, but are deemed appropriate and stable. So we still went ahead with no problem with all of these individuals. And in terms of the neurologic status and the FES contraction and pain with FES at baseline is really interesting, because we have found that actually quite a few individuals reported discomfort and pain in different locations. They had pain where the stimulation was, with the electrodes. And also some felt pain in the groin, so it was referred up there in the groin area. But somebody reported even pain, in the spine. So even though they had stimulation, right, peripherally, but they reported pain in the spinal area. And that was very interesting. And obviously, with all of that reported, we had to do something about it. And first of all, did people want to stop? Guess what? Nobody wanted to stop. They all wanted to continue. And so our staff just basically adjusted the parameters with the stimulation parameters to try to make it more comfortable. So we may have to turn down the stimulation or adjust other parameters to make it more comfortable. And that was it. After it was adjusted, they all just carried on with no problem. So that was one big lesson that we learned from there. And then in terms of the stimulation itself, you see that some people really could not tolerate very high stimulation parameter. So one participant was quite apprehensive and really maxed out, at 35 milliamps. But then other people could really go as high as 80 milliamps and 140 milliamps. And you also see that essentially, right, especially those with incomplete injury, they felt that more, and so that was more of a barrier than those with complete injury who really did not report as much discomfort, so they could really be cranked up higher with the stimulation. And So this just really summarizes what I just talked about in terms of the pain. And in terms of contraction, some people did not have a lot of contractions, but actually most people did. And so that was very good. Even early after the injury, they all had strong contractions. And in terms of adverse events, basically we had a number of things recorded, but related to FES, it's mostly the pain that I reported earlier, and also one person reported FES triggered spasms, but at the same time that did not really stop him from carrying on, so there was no problem at all. So we was really pleased to see that. And now there was no problem with autonomic dysreflexia. There was a question that was always asked by everybody, but nobody reported AD at all. And so in terms of participant feedback, it was really quite positive. 5 people responded and they all really felt really good about it and felt that it was beneficial emotionally and would recommend that to their friends. And then they wanted to, uh, um, do that, as you see, because they felt like it could maintain muscle mass or tone, and also they're looking forward to doing something there. And then in terms of clinician feedback, we had 11 respondents, so that was fantastic. And it was really exciting to see that the clinicians had really positive feedback. And they felt that it was really very motivational for the participants, and they maintained a positive attitude, and they were very supportive for the use of FE cycling in the acute care setting. That was really something that I didn't know, that they would report, but they did. So that was really excellent. So what did we learn there overall in terms of safety and feasibility? We learned that for FES cycling, it was fine to start there as early as 12 to 33 days post SCI. And now our sample size was limited by people transferring out of acute care hospitals. So it really showed that, okay, we need to think more about, do we really start it there and then continue that in the rehab setting, or what should we do? So that's something that we need to think more about. And spinal shock really wasn't a big issue that we had. And then in terms of progression, which I really did not go into much here, like I say, there was a separate paper. It was really highly individualized. We couldn't really come with a standard protocol. We have to look at people's pain response and also how they really responded in terms of their contraction and what power output they had. So it's really highly individualized. And in terms of our adverse events, we reported some pain response that people had, though it did not really stop people from using FES cycling, but it's something that we need to think more about. And there's no AD reported. And the participants were really enthusiastic, but some were apprehensive, so we have to keep that in mind, right, after an acute injury. And the clinicians really enjoyed that. And in terms of a longer term follow-up, I was really excited to find that 5 out of 7 of the participants actually continue FES cycling without prompting at the YMCA, and one couldn't do it just because of COVID-19, but she said that she would have done that anyway, if it's not COVID-19. And we really value the engagement of the acute care clinicians and administrators, because they really made this study possible, and hopefully that will translate to implementation in future. And continuation of FES cycling at the rehab program was important, because what if we get it started, but then it couldn't be continued in the rehab setting? That was a big question, right? So the next steps are as follows. Clinically, FES cycling is also available in the community more than the rehab settings in Canada, anyway. And so we are looking at how we can get this going in the acute care setting, and then also more, to support that more in the rehab setting. And we are thinking that, we should think about how we may use the supine FES spike in the ICU and acute care setting, and also think about psychological benefits as well. In terms of research, um, we need to really look at how FES cycling in the acute setting may have an effect on neural recovery and also the neuromuscular issues that I talked about. So we are very fortunate that we recently got funding by the Praxis Spinal Cord Institute and the Craig H. Nielsen Foundation to perform pilot studies over the next 2 years to determine if early versus no FES cycling and if early versus delayed FES cycling has any benefit in neural recovery. And the goal is to use this as a pilot studies with results that we can use as the basis for a multi-site RCT in early FES cycling in future. And also, given our initial data, we are very lucky to be able to study the impact of FES cycling from the user standpoint. I think that's something that's so important. That's not reported in the literature. How we need to understand what the users feel are the benefits and how that impacts on their psychosocial being and their emotional well-being and the quality of life, and so with the support of Dr. Hope Jervis Rettermeyer and Dr. Kristen Musselman from the University of Toronto, we are embarking on that study. And also we'll be studying the health economics impact with Dr. Brian Chan, also from the University of Toronto as well. So before I finish, I just want to acknowledge our multiple funders for this work, my wonderful lab team, and also the multiple collaborators who have made this possible. And in particular, Riccardo Bordini, who's a person with lived experience with SCI. He's been guiding us with the design of the study and participating as a research team member, and really want to acknowledge his participation. Thanks very much.
Well, we would like to thank you so much for taking the time and the opportunity within your busy schedule to participate in our FES and technology task force and provide us with this very informative presentation about application of FES in acute stage. Apparently, this is really extensive data collection, and I would applaud you and applaud your effort with your team to collect all this extensive data uh, and basically enlighten the road to the importance of studying more or providing more studies for applications of FES in acute. Um, I want to start before opening the session for question by saying that I really like the fact that you have engaged or have implemented the supine FES cycling in your study, because this is, uh, to me, I was always wondering whether there would be some variability or some differences between application of the supine FES compared to the sitting FES. Which is I'm going to ask you about this later. Um, but one of the things that's really striking me, and Dr. Ho, you may just really kind of like guide us into this and maybe guide some of the audience. Why do you think that application of FES may different from acute to chronic? Considering the fact that we know that at some point that person with SCI, I don't want to say reach a steady state, um, um, but at least we will know that he will reach a steady state, but with a continuous decline in muscles, bone, increasing fat. But why we think that application of FES in acute stage may benefit those with SCI? That's my first question.
Sure. And so I think that in terms of the application, um, you know, what we are really hoping to see is that if we could start this early, could we actually prevent, right, all the muscle atrophy and bone loss that would occur so quickly? Because I think that the thing is, if we look at the things that we do, I would use my context here in Canada. In rehab, we focus a lot on how people may actually go home safely. And I have to say that I don't think that we focus as much on the prevention of secondary complications and also on neuro recovery. And so people, will go home from rehab, and then they may start FES cycling or something like that in the chronic phase. And by that time, the muscle atrophy and stuff have already set in. So could we do something earlier? And that's one thing. And in terms of the application, the actual application, so as we found out, there's so many different medical complications that people need to think about in the acute phase. Can we really do it? And can we do it safely? And it's really quite different from looking at people with chronic injuries, because with chronic injuries, apart from the fact that physiologically speaking, they're different, but also in terms of how people have adapted and adjusted to the injury, that's very different. And so people are still really going through adjustment period. And so the use of technology like this and treatment like intervention like this, it may be received quite differently um, in the users. And so that's why we wanted to learn more about that. I don't think we really know all of the answers yet, and that's what we're trying to find out.
Awesome. Great. I'd like to open for the rest of the panel to ask a question, and for the folks who have attended the presentation. So any questions?
Hello, Ashraf. This is Jean. I have a question, if I may.
Sure.
Thank you so much, Dr. Ho, for that wonderful presentation. I've had the privilege of working with some of the inpatient therapists in our spinal cord injury unit who are interested in looking at FES and incorporating stimulation of trunk musculature to look at its potential effects on posture and benefits for seating. And one of the challenges that we dealt with in figuring out how to design a study around this was how to approach the control group to be able to look at what the effects of FES were, given that this treatment is happening against the background of all kinds of other treatments and some potential recovery. And initially, we tried forming a group based on folks who had some contraindications to FES that were not disruptive to other aspects of their therapy, but found that over time, the criteria evolved such that our control group was sort of disappearing. So I'm wondering what advice you might have about how to approach control.
Yeah, Jean, that's an excellent question, because when we were actually submitting our protocol to the Craig H. Nielsen Foundation, we had the same question, right? How on earth do we design a controlled study, right? Because is it ethical? Is it actually feasible? Because who on earth would want to get into the control group, right, when they know that there are actually potential interventions there? And so this is how we got around it. And it was a tough one. And basically, in our setting here in Edmonton, we actually have two facilities that, take people with acute SCI. So we actually started the work at one facility at the University of Alberta Hospital. For the other hospital, it hasn't started. And so we're trying to use that as our control group here. And so, we really were struggling with that, because is it fair that we don't do that at the other side? But then naturally, it just hasn't happened there. And that's why we felt that probably would be the situation. So my thinking is that maybe, one would collaborate with, let's say, another facility, maybe in a different city or different setting altogether, and use that as your control, because within your same facility, it would be so difficult. But then when you think about different hospitals and different cities, then you have to think about all of the different situations, like the different potential different standards of care, different populations, etc. So then when you think about all of those, then you really need to have a power enough, right? To like enough sample size to account for all of those. So it is a really tough one here.
Well, thank you
Yeah.
for that. Thank you.
Sure.
And Jean, I may have to add to Dr. Hu, based on our experience, we have a similar problem submitting our protocol, and we have designed our control group in a way that they can still getting the stimulation, but in stimulation parameters that we don't think it will work, or it will cause the same effect. For example, if we're looking for muscle hypertrophy, we know that there is a specific parameters based on literature that may help evoking muscle hypertrophy. So we will deliver stimulation that can also trigger sensation or subtetanic stimulation, and we call this our control group.
That's helpful. Thank you, Ashraf.
Sure. Any other questions from the audience to Dr. Hu? And very, very great presentation. And hopefully, Dr. Hu, you would just really next year you would be able to fill us in about the progress of your study. And I knew today you mentioned that you're going to talk more about the safety and feasibility, but we're really excited to see some of the physiological parameters, and even if it is possible to share with us next year around this time.
Sure, that'll be great. And I have to say that for our recruitment, my goodness, for the last year, we have been really slowed down by COVID.
Yeah.
And so, for many months, we're not even allowed to be in the hospital, right?
Right.
For our research team. And so we are a bit behind, but we're trying to catch up now.
Yeah, I think we are all on the same boat here, and we have been hit badly, but I think we are now in our recovery path, and hopefully we can make progress in the next few months. Um, if no further question, on behalf of ACRM and on behalf of the FES and Technology Task Force, we would like to thank Dr. Hu and thank his team for this interesting work. And hopefully next year, Dr. Hu will agree to join us again to provide us with update about the work and the future of FES, specifically in regard to acute applications in persons with SCI. Thank you, Dr. Ho.
Thanks so much for having me.
Sure.